Good evening, everyone. Thank you again for coming to our academic forum this evening. So the topic is ill and injured child. We've broken into two parts tonight. The second talk will be by Adam Chesters, and that's on the traumatic child or traumatic injured child. And the first talk is on NLS, so a really important life skill I think you're just going to be thrown into, and actually it's a really nice refresher of remembering that quite complex algorithm. And we're really fortunate for that to be delivered by Georgie and Kev today. Georgie's an ED training lead, and they're both resus practitioners, and I also worked with Kevin on the road as a paramedic, so we're really grateful to have them tonight. So we'll hand over to them. Thank you.
Okay, hello everybody. Yes, I'm Georgie. I work at the West Suffolk Hospital and I'm their education training lead. So I'm going to talk through a few different approaches to resuscitation at birth. Okay, so hopefully this lecture is going to enable you to develop a logical approach to resuscitation at birth. We know that most babies are born, as soon as they come out they start screaming, but there are a few babies that need a little bit of assistance. So we're going to think about those things now. So equipment, obviously both sides you can see there are for in hospital. However, out of hospital you have the bare basics, as you can see in the middle pictures there. You've got you might have some suction, you might not. The midwives that tend to go out to these births just have a stethoscope, some towels and a hat, and not much else really, but we'll talk about a few more bits in a moment. So when the baby's born, we obviously they're going to be cold and wet straight away. So we first of all think about drying and covering the baby, which is really important. We want to get rid of those wet towels and wrap them in nice warm, hopefully fluffy towels. If they're born in hospital, they're often very rough towels, which perhaps helps with the stimulation. And we want to assess that situation straight away. And then we follow the lovely sequence. We think about airway, you're breathing. Do we need to give those inflation breaths? If all these things aren't working and we still have quite a slow heart rate, do we need to think about doing some chest compressions? And then unfortunately the last thing is drugs, and by then that's often bad for prognosis. Okay, so I've already said, as babies come out small and wet, and obviously they get cold very quickly. So obviously if they're born in the back of the ambulance, in the middle of in a car, can be born in a field, in a car park. I've helped deliver a baby in a car park. That's quite interesting. They're going to get cold very, very quick. Okay, we know they lose their temperature. So the first thing, as I said, we need to make sure we dry that baby and then cover them in hopefully warm towels. The baby in the car park, I wrapped in mummy's lovely dressing gown to try and keep warm, but you never quite know where you're going to have them delivered. Okay, so first of all, we like to start the clock. So if you did, any of you did attend a birth, it's always a good idea just to have a look at your watch or a clock and put some sort of time down, okay? Because if you do need to start resuscitate them, the one thing we need to know is how long we're going to go on for, okay? So we need to start that clock. Drying the baby give it good old stimuli, so hopefully you're going to wake that baby up if you need to, and obviously you're going to assess the situation. Most of the time when babies are born, we tend to leave the cord attached and we just lay them onto mum. Little bit of drying, old rough towel or whatever, and normally gets that baby to respond, but not always. And you need to be thinking straight away, do you need that extra help? You might be that extra help, okay, but do you need that extra help? Okay, so we think about certain things. We say one thing that's probably not on here, but we say, is the chest moving? Okay, so have we got chest rise is the key thing. So have those lungs been emptied of all that fluid? So that's the first thing we think about. We think about, is there a heart rate? So we don't listen to it for a minute. You just listen with your stethoscope or whatever. I mean, if you've got the ECG leads on, whatever, you listen to see if it's a fast or a slow heart rate. Okay, that's really important. Obviously, you need to know if that baby's breathing. Okay, that's important as well. Very important. And the colour and the tone. Okay, so most babies will come out looking quite blue, but after a few gasps and a little bit of breathing, they normally go pink quite quickly. All right, so just think about those things. Okay, so this is where it's up to hopefully you to decide. But so this is a baby. This is baby 1. Okay, it's born blue, but soon goes pink. Has got a good tone, so it's crying. Breathing's regular, and there's got a nice fast heart rate. What do you think you might do to this baby? So this baby's born blue, goes to pink quite quickly. Got a good tone, breathing nicely, fast heart rate. Absolutely. Who said yes? So we're going to dry this baby, wrap them nice and warm, and hopefully give to mum. Okay, so that's what we want. That's a good birth and everything's going well. Okay, so this next baby we call baby number 2. All right, so this baby's blue, not pinking up at the moment. Okay, moderate tone, breathing irregularly, and it's got a slow heart rate. So what things am I looking for there? What do I want to do? So I want to dry and cover that baby and stimulate at the same time. Yeah. What about? Absolutely, start the clock. Pardon? Check the airway. Yep, absolutely. So we're going to check the airway. Okay, and the heart rate's slow. So let's have a look what we're going to do. So we're going to dry and cover. We're going to open that airway, and we're going to maybe give those inflation breaths, which I'm going to talk about in a moment. Okay. Okay, so this is baby 3. We're getting a little bit worse now. So this baby's blue, all pale, which is a bit of a worry. Very floppy, not breathing, and slow or very slow heart rate when you listen. So start the procedure again. What are you going to do? You're going to start the clock. You've already told me that. What else? Okay, dry and cover the baby. Yep. Stimulate at the same time. What about this airway? Which position do we want to put the airway of a newborn in? Neutral position. Lovely. Okay, and then do you think we're going to give those 5 slow inflation breaths? Yep, so we're going to give those 5 slow inflation breaths, and then we're going to reassess and see. Just like it said there, it's quite repetitive, but we're going to dry and cover, we're going to open the airway, we're going to give those inflation breaths, and we're going to reassess. Okay, this baby may need some extra help, okay, so think about, do you need that extra help? Okay, so airway. In the unconscious baby airway, it's not obstruction, it's usually due to loss of pharyngeal tone, okay, not that you have any foreign material in the airway, okay. So it's position, not suctioning. So we want to put that head in that nice neutral position. That's so important, okay. Most babies, or nearly all babies, won't need suctioning. There's only one time you might suction a baby before you start stimulating that. Does anybody know what that might be? Yeah, okay, so if a baby's born in thick meconium, okay, look like Shrek, all right, and they come out and look quite green, covered in thick mucousy stuff, okay, you might then have a quick look before you stimulate. Do you know why you might look before you stimulate? Yes, because they could gasp and then aspirate. You're absolutely correct there. Lovely. Okay, so we want that head in that nice neutral position. That's the first thing. So the baby's born. We've started the clock, we've given a good old rub to try and dry the baby, and we've put nice warm towels. We've put the head in that neutral position. Okay, there's 2 pictures there. Okay, so can you see the nice neutral position on the second picture? Yeah, you can. Okay, so that's a nice neutral position there. We're going to apply the mask with the jaw support. So in a moment you're going to see a T-piece, which is often what we use in hospital. However, I prefer a bag valve mask, and obviously you have it onto air. So let me just show you that. So that's your T-piece. So we check, we do the 3 Ps, we position over the baby's nose and mouth, we give a little bit of pressure, and we pull the airway up into the mask. Okay. If you've got a bag valve mask, it's the same thing again, really, with the little mask. You put the mask over the nose and the mouth, and again you position, pressure, and pull the airway up. Okay, so we're going to give inflation breaths, and we're going to start with air. We always start with air now, not oxygen. Okay, so if you have got your bag valve mask, you don't need to attach it to any oxygen. You just start with a bag valve mask on air. Okay. These inflation breaths are going to be really slow. Okay, they're going to be over 2 to 3 seconds. It says at 30 centimetres of water pressure, but if you think about it, you could just use your bag valve mask like we said. And they're going to be over 2 to 3 seconds. Okay, why do you think that is? What's in the baby's lungs?
Surfactant, hopefully.
Yeah, well, yes. What do you want to try and get out of the lungs? Okay, so there could be about 100 mils, okay, of fluid in those lungs. So by doing slow, sustained inflation breaths for 2 to 3 seconds, you're hopefully going to push that fluid out of the lungs, okay. So we tend to go 1, 2, 3, 2, 2, 3, 3, 2, 3, 4, 2, 3, 5, 2, 3. So each one of those is the way we press our bag valve mask, or we hold the T-piece down. That just delivers those at a nice slow pace. Okay, so we give those inflation breaths, then we're going to reassess. What are you hoping to find when you reassess? What are you hoping the heart rate's done?
Increased.
Yeah, because if you hopefully you've got good chest movement and you've got the heart rate has increased. That's what you want. How are you going to assess? Well, maybe a stethoscope, you might have pulse oximetry, or you might have little ECG leads on. It depends what you've got and where you are, but that's the way you're going to assess that heart rate. And again, we don't go, as I said before, you don't go for that whole minute. You just want to know whether it's fast or slow. If your heart rate has increased, you can assume that the lungs have been inflated and the fluid has come out. Okay, so you've got, and the one way you might know that is by seeing good chest movement. If the heart rate does not respond, then on the inflation breaths, then either they have not inflated the lungs, or the heart might need some help to respond. Okay, which way will depend is if you've seen chest movement. Okay, so that's really important. If you've seen chest movement, then you can move on to the next steps. If you haven't seen chest movement, you might need to reposition or do a 2-person jaw support to obviously get those inflation breaths in. Okay, so the chest is not moving, the lungs are not being inflated, we need to go back then. Okay, we can't move on. So that's the most important thing of this algorithm. If you've seen no chest rise, you cannot move on to the next part of the algorithm. You have to see the chest rise, okay? So you might use a 2-person technique with a jaw thrust and a T-piece, or your bag valve mask case. So one person would hold the mask on and obviously pull the bottom jaw up in line with the top jaw, hitting the head in a nice neutral position, and then the other person might help with the puffs on the T-piece, or they may help with the bag inflations, but you're going to deliver another 5 slow inflation breaths. I don't know why they put a child on there, but they're just trying to show you how to do your jaw thrust as such, all right? So you can see in 1, the jaw at the bottom is lower, and in picture number 2, you can see the arrow as the way you push the jaw up. Okay, it might be that you might be on your own and you've got nobody else there, or you need another pair of hands. So we often say maybe put an oropharyngeal airway in, so size it up and get ready. We do always suggest that you have the suction ready. So if you're going to put an oropharyngeal in, we do that by direct vision. Okay, so we often use a laryngoscope, or maybe a lollipop stick and a torch out in the community. It depends what the midwives have got, but you will only put an oropharyngeal in with direct vision. Okay, you won't put it in if you've got no vision at all of the airway, so that's quite important. So it's all about sizing it up, and then hopefully that might hold your airway open so you can get those slow inflation breaths in. Okay, we've had a quick thought about meconium, but if screaming babies, obviously they have an open airway, there's no need to look. And we've said about if they're floppy at birth, then have a look. So we're thinking about that real thick mucus, lots of blood and lots of vernix before you should even have a little look. Okay. Otherwise you start, as we said, the stimulation and following it that way. Okay, so we said again inspection and suction. So laryngoscope, left hand laryngoscope we might use. We'll have a large bore sucker, and we'll always suction under direct vision. Okay, if you're not trained in doing suction, then we wouldn't be doing suction. You need to be trained to be able to do all those things, and again to use the laryngoscope correctly. Okay, so the heart rate has increased and is now above 100, but the baby is not breathing. Okay, it then says we should, on the algorithm, we should then ventilate at 30 breaths per minute until the baby is breathing well. Okay, that's quite important to think about that. So your heart rate has increased and is now well above 100, but your baby's still not breathing, so they just might need a little bit of assistance. So we just do 30 seconds, okay, until the baby hopefully is breathing quite well on their own. It's all done in short periods of time, so we don't go like you might for an adult or child 2 minutes at a time. We just, every 30 seconds we would reassess. So we just might need to do 30 seconds of ventilation breath just to help speed everything up. Okay, so the chest is moving, but the heart rate is still slow or absent. We know that. So we're going to think about 30 seconds of ventilation. Talked about that, and we're going to confirm the chest movement. If the heart rate still remains slow, this is where we need to move on to chest compressions. Okay, so chest compressions are done again differently to an adult and done differently to a child. So for this newborn, how do we do our chest compressions? Anybody know what the ratio is? I'm liking it already. What is the ratio?
3 to 4.
Lovely. So the ratio is 3 chest compressions to 1 breath. We do it for 30 seconds, and as I saw somebody out there in the audience, we encircle, which is the gold standard. Sorry. So you encircle the chest, and obviously you put your 2 thumbs on top of each other, and you compress the chest. You're absolutely right. Or you can use the 2 fingers technique. Okay, so what you're trying to do with your chest compressions is you're going to move your oxygenated blood from the lungs, hopefully to the coronary arteries. That won't take long. It's not far. It's a little person. Okay, so hopefully it's going to work. But obviously now we're a little way into the process. We might start having to think about putting a little bit of oxygen with the air. Okay, so you might want to plug it into your oxygen cylinder or whatever you have. Or you might have to start thinking about giving some supplementary oxygen now. Okay, so we're going to reassess again. Has the heart rate improved? Unfortunately, no. So we've checked the airway, we've checked for chest movement, and we've checked for chest compression. So we've done all of those things now. We're following this algorithm through. We might have to consider some drugs now. So we think about these 3 drugs as, well, we used to have it as bad because we used to have bicarbonate, adrenaline, and then dextrose, but obviously, as you can see, we've called the same thing with glucose. So we think about these drugs, and they're in very, very small amounts if you are going to give them. If you do have to give the drugs, we're going to have to think again and start reassessing. We're going to think about the temperature of that baby. We're going to think of the blood sugar, because we know that the baby's blood sugars are going to drop quite quickly as well, because obviously the body's trying to resuscitate itself. We need to be thinking about those parents as well. Okay, explain to them what we're doing. You know, if we suddenly start doing chest compressions on their little baby, maybe we need to start talking to them, explain to them what we're doing, if we've got enough pairs of hands. If we're going to record, we need to obviously document and record very clearly in notes, again, wherever we do our documentation. And we need to think about debriefing and looking after each other. Because if you've witnessed a baby that you've had to resuscitate right down to drugs, and then unfortunately they don't make it, it's good for us, we need a team debrief, okay? There is poor prognosis, we know, if there's no heart rate at birth and still absent at 10 minutes, okay? If you look at a lot of the research, if you haven't had a heart rate at all and you still haven't got one at 10 minutes, the prognosis is often quite bad. That's the end of the lecture. I'm going to do a couple of quick talk through scenarios with you. However, is there any questions on what you've just seen?
If you're using a bag valve mask, isn't it safer to either intubate or use a supraglottic device? I mean, how much chance is there for, insufflation in the stomach using a bag valve mask?
So if you speak to most of the paediatric consultants and that, intubation is the very, very last thing that they'll do. Often we will start with your bag valve mask. I don't know if you want to answer any more on that, Kevin.
Yeah, the gold standard nowadays, intubation is only for babies who have slowly recovered and they're maybe moving on to a neonatal unit. So it's the main thing for resuscitation is at the very best oral pharyngeal airway will suffice completely. There's a lot of evidence out there. Actually, some of the iGels and some of the airway agents that we've got available to us aren't great on a newborn. So for basic resuscitation, an OP airway or even just your basic manoeuvres, hand manoeuvres work a lot better. And certainly I've run into hospital with a sick child, a baby who's not breathing, just with an OP airway and ventilated for 20 minutes all the way in, and perfectly well the child was ventilating. If you start using other stuff, there's more problems going to probably arise, and just a simple bag valve mask will work perfectly.
Any other questions?
Yeah.
Sorry if I missed this, but if you have to do supported ventilations to a child that's got a heart rate you're happy with, what rate do you give the breaths at?
So we're going to the ventilation. Yes, okay. So the inflation breaths will be 2 to 3 seconds, but the ventilation breaths you want about 30 in 60 seconds. So 1 off, 1 on, 1 off, 1 on. Does that make sense? Yeah. Sorry if I didn't say that. Is there any more questions?
In terms of
Oh, sorry, it's blinding. Yeah.
In terms of the drugs and delivery of the drugs, when it comes to access, where would be a good access route to give those drugs through? Where would you recommend?
Okay, so depending on what your backgrounds are, I'm not sure. If it's out of hospital, I suspect you'd use the IO. Easy IO. In hospital, we tend to use the umbilical cord if we can get access through there. I don't know what else you would.
Certainly pre-hospital, you'd be looking at doing the IO on a child as such. There's some discussion about using going through the ET tube, but actually we've already discussed ET. You speak to a paediatric consultant, anaesthetist, and that they're really reluctant to do ET tubes on children as such. We'll just manage with it, and certainly with an OP. So I would opt for the easy IO with a newborn every time.
Any more?
Is there an optimal site, you'd say, for a newborn with an easy IO? Because obviously we've got so many different sites and new growth plates in the child. Where would be the
The
best?
tibia plateau. Just go there.
Any more?
There is an online question. I'm just going to say it with a microphone so the stream can hear as well. Somebody asked, how much oxygen would you recommend when you get to the stage of needing it? And just sort of questioning about what are acceptable preductal sats.
Very good. Preductally, obviously, for SATs for a newborn, that they are, we know that they the oxygen, they survive really well with low oxygen for quite a long period of time. So up to about the 10-minute stage, your oxygen saturations might still only be around about the 80-85, which is actually acceptable in a newborn resuscitation. I would always try for the first few minutes of just using normal air as such, and then slowly start to titrate the oxygen in over that period of the resuscitation. Start off with maybe 4 or 5, then move it up a little bit more, right up towards probably 10 towards the end of my resuscitation. I'm probably very reluctant to turn up to full 15 litres, because babies don't tend to need massive amounts of oxygen as such, because obviously they survive quite a long period of time with low oxygen, being inside mum and obviously being supplied through mum's bloodstream, which isn't 15 isn't 100% oxygen in mum's bloodstream.
Thank you.
Any more questions? Yes.
Sorry, just one more. Paramedics are very concerned, or would have been concerned if their training was a few years ago, about retroankle fibroplasia. Is there any risk of that with giving high oxygen concentrations to neonates?
And that's the main reason why we don't use it. We just go for room air as such. I certainly the ones I've been involved with, unfortunately, there have been a few. I have not gone above 10 litres of oxygen on a newborn, and most of the time I've just sat there and just used room air until I've actually got to hospital with a child, or we've got to the stage where nothing's worked and we stopped. It's quite acceptable to carry on resuscitating a newborn just on normal air without necessarily giving lots of oxygen and running the risk of even worse things happening. But obviously you've got a resuscitation going on. It's a case of resuscitation, or having the risk that you suggested. The baby's really sick already, so but just room air would be probably fine with a little bit of titration rather than massive amounts of oxygen.
Any more questions?
One more from the live stream. What's a normal blood glucose in a newborn, and sort of what point would you consider that?
It's about 3.6.
Yeah, so it's low actually compared for adults as such. It is literally the high 3s, around about the 4 sort of level is sort of normal. When it starts dropping below that, because the baby's used up a lot of its blood glucose over being delivered, and obviously, as Georgie said, they're trying to resuscitate itself as well through the physiological matters. So once it drops below 3, I would be thinking about sticking something in there as well.
Any more?
That's it.
Yes.
Exactly what class is neonates when you're days and less.
Oh, that's a really
Yeah.
A bit of a question.
So if you were to ask the paediatricians at the West Suffolk Hospital, which is just my local hospital, so that's all I'm going to say by those, they would say that if they go from the delivery room into the neonatal unit, you would be using the 3-to-1 or the NLS algorithm for the first, until they go home. The minute they go home, they're then classed as the paediatric child, so they would then go into your 5 rescue breaths and 15-to-2. Does that make sense? So that's what we class. If the baby's born at home, okay, and then comes in within the first 28 days, again, we will normally go as a paediatric child rather than a newborn. But that would differ, yes, absolutely. any more questions? Okay, so just to summarise, but I'll talk through as a scenario to summarise. Most babies are born and they start crying quite quickly, and we know they're born quite blue. The most important thing is we obviously need to do that quick assessment. So unless they're covered in thick meconium, we will give them a good old dry with the towel, put nice warm towels on, nice little hat on, reposition their head in that nice neutral position, and we will look at their colour, their tone, their heart rate, has there been any chest movement, and is our baby breathing? That's the first things we do on our algorithm. If we still haven't not seen our baby breathing and no chest movement, we will deliver 5 slow inflation breaths over 2 to 3 seconds. After those 5, we reassess, okay? If we still haven't got any chest movement, we can't move on to that next step. So we will then reposition with maybe a 2-person technique, all on pharyngeal airway. And again, we would give another 5 slow inflation breaths. If those 5 inflation breaths work and we see good chest movement, okay, we then need to assess the colour and the tone of our baby, and has our heart rate increased. If our heart rate still hasn't increased, but we've got chest movement, we then do 30 seconds of ventilation breaths just to see if we can get that oxygenated blood around that body to speed that heart rate up. If we give those 30 seconds of ventilation breaths and we still have got the slow heart rate, then we need to maybe do those chest compressions. And we're going to do those chest compressions, 3 compressions to 1 breath at a good rate. They say about 100, the speed is about 100, like an adult or a child. Okay, so we're going to do 3 to 1 for another 30 seconds. After those 30 seconds, you're hopefully going to see a fast heart rate, baby breathing, nice pink, nice colour. However, if you don't, we may start having to introduce drugs. But we know this algorithm works. Okay, so you can download the algorithm on the Resuscitation Council NLS algorithms. It's worth downloading and having a little look. But what I would say, you have to follow the sequence of events to make it work. If you have no chest movement, then you can't move on to the next one. Thank you very much for listening to me. Thank you.
Right, thank you. We're just going to have a quick change of technology. Okay, just double check that we are working. Great. Okay, so this is great. I don't get to speak second that often, so I can go on for as long as I want without worrying about bumping into the next speaker, which is excellent. And Georgina, you're absolutely right. That was a very bright light up there. Okay, so we're going to move now from that critical neonatal life support that we don't do that often, but we have to think about it because we don't want to be thinking about it when it actually happens. We're going to move on now to another rare event, another relatively rare event, which is pediatric major trauma. Over the course of the next 45 minutes or so, I'm going to try and go through, in the context of a case, some of these things. So I want to talk a little bit about calculations. I want to talk about parents and parental involvement in these cases. I want to maybe just give you a few pearls or snippets of specific considerations for children versus adults who are injured, because again, it's a fairly rare event and we can't just transpose our adult knowledge onto children. I want to get you to think a little bit about your own equipment, your own systems, and your own Preparation, so your own practice, which involves your mental practice as well as your physical practice of these situations. We'll touch on triage in the context of a case, and then I want to just finish with some suggestions as to how you might be able to look after yourself and your team after the event. It's a good job I'm going second, really, isn't it? Okay, so I think that in general, most of us learn experientially, so we learn from cases. I think we all have cases that we don't forget and that we learn from, we take those forward, take those learning points forward into our next cases. So I want to try and share one of my cases with you, which is very much one of those cases for me. It's one that I think about quite a lot in terms of how I'd approach things and how I approach ill and injured children in my daily practice now. So this was 3 years ago, over 3 years ago now, April 2016. It was, we'd had quite a mild February, March, and then suddenly we got hit with an early morning frost on this morning. It was a Wednesday morning, I think. And we got hit with a morning frost. I remember sitting in my car and having the heaters turned on for 10 minutes, and it was noticeably much colder that day, and the ice had built up. I arrived at work on the helicopter, doctor paramedic team, based out of Cambridge, and we got a fairly early call. We got a call at about 8 o'clock, 10 past 8, something like that. We'd been on duty for half an hour or so. And it was a call located in just north of Luton. So you can see on the screen there, just at the top right-hand side as you're looking at it from the lecture theatre, you can see that's Cambridge where we are. And you can see that the incident location marked by the blue pin just north of Luton. And that's about a 15 or 20 minute flight from Cambridge. You can see probably the proximity to Luton and Luton Hospital, Luton and Dunstable Hospital. That would be the local hospital. So as ever, when you're arriving by air, you get a unique viewpoint, a unique perspective of a case. And this is pretty much what we saw from the overhead. So lots of fields to land in, a sort of farm area with a sort of industrial outbuildings, and then quite a nice looking house, which is just in that triangle there you can see. And as we got lower and lower coming into land, we could see that this was obviously a well-manicured house with a driveway, trampoline, children's toys around the place. And the job that we'd been sent to was a 2-year-old who'd been run over by a car. So a little unusual. We were expecting, a pedestrianised road or a road with, that you would expect cars to be driving up and down. It was a little unusual to be out in the middle of nowhere. And it soon became clear that what had happened was a car that was stationary on the driveway had rolled forward and run over this child, and that was how the child had been run over. And that was pretty much the only information that we had flying to the incident. So just as a pause there, not only do we receive minimal information when we're going to an event with the helicopter, we also receive minimal information on the pre-alert call when we're waiting for children to be brought in by the ambulance service into the hospital. And whether or not you're in the hospital or in a helicopter or doing an APLS course, quite often this is one of the things. Is everyone familiar with this sort of thing? You get this pre-alert for a child and somebody goes, "Oh, quick, someone do the calculations." And the idea is that there's a whole series of calculations that you should do for a child of a certain age to work out drug doses, weights, equipment sizes, etc. And what you ordinarily end up with is some spider death on a whiteboard looking like this, that's got maybe some of the previous day's calculations written on it, and you don't quite know whether that's 600 or whether it's 60, whether it's milligrams, micrograms. Somebody's showing their working here, so they get all the marks in their maths test. Some long division going on, and it's not uncommon. This is a real picture that I took in one of our local hospitals when we were waiting for a child to come in. It's probably, in my view, not the time to be doing those calculations when you're under pressure, and it's certainly not the time to be doing those calculations when the output of those calculations is something that maybe isn't that useful for the team leader or for other members of the team to have a quick glance at, look at it and understand what's going on. Clearly, something like that in front of you is not going to be quite as clear as you might hope for. Add into that the pressure of setting up a resus bay, the pressure of being in the back of the helicopter, looking out for other aircraft, looking out for threats to the aircraft, using the handheld push-to-talk button to transmit across the radio, listening to the pilots, listening to air traffic control, all those things going on that might increase the chance of you making a calculation error. So not only are you producing a scribbled piece of paper on a whiteboard or on your kneeboard, you're potentially going to make errors here. And this isn't just me being on a soapbox, there's a little bit of literature behind this. So this was published in 2008 in one of the pre-hospital care journals, and it looked at drug calculation, paediatric drug calculation errors by pre-hospital care providers. And they took 500 advanced paediatric life support providers. They gave half of them pre-printed cards with the calculations on them already, and they gave half the task of calculating the doses, the equipment sizes, using standard formulas but without the pre-prepared cards. And you can see here that there was a statistically significant difference in the level of correctness. So using the card, 94%, just transcribing from a card, 94% got that correct, 6% got it wrong, which says something in itself, I think. But 65% got it right using the calculation. So to me, that's quite a worrying number. 35% incorrect calculations, not particularly under that much pressure, just doing as part of a study. Add in the helicopter, the noise, all those other distractions, setting up a ped resus, trying to manage the crowd that's forming when you put out a paediatric trauma call, plus your adrenaline, plus all the other distractions. I would strongly suggest that if you don't have it already, you rely on your age per page, pre-printed, pre-checked, double-checked, triple-checked calculation cards. So no more whiteboards in resus, no more scribbled notes on your knee pad or in a notepad, something that you've got in your pocket or in your resus room that you can just take out, put up on the wall instead of the whiteboard, and it will be correct. The added advantage being, of course, that if the 3-year-old actually turns out to be a 6-year-old, your calculations you swap the card over. You don't need to redo the calculations, which is quite common for us to arrive to, isn't it, when we get a call to a 5-year-old that actually becomes a 15-year-old. Okay, so calculations and cards. So if you do nothing else, those of you who are from hospitals, if we can have a mass burning of all of the whiteboards in the east of England, that would be excellent, if you wouldn't mind. Okay, so let's go back to this case. So what had happened? Well, remember the nice little driveway and the manicured garden at the front of the house? It was that unseasonably cold, frosty morning. Mum had come out, had turned the car on, like most of us do, to preheat it, and the 2-year-old was toddling around the car. Unfortunately, something happened, the gear slipped, the handbrake slipped, and the car lurched forward, took the 2-year-old with it underneath the bonnet, and pinned him face down in the slightly elevated garden section, so that the the toddler was face down with the weight of the car on top of him. Wheels hadn't gone over him, but the weight of the car was on top of him, pinning him face down in the dirt, in the mud, in that flower bed. Clearly not something that one might be prepared for coming to one of these jobs, which is the point of thinking about it in advance. Just as we were walking up to the scene, or running up to the scene, as you often do with these paediatric cases, we could see that some of the local farm workers had come out and had physically lifted the car up to enable the child to be dragged out. So what we saw as we came into that gate was this purple, blue, lifeless looking child being dragged out so that the paramedics could start to work on them. So think about trying to do your calculations now with that level of adrenaline going on. Think about how much easier it would be just to have one of these in your pocket that you could look at. So the next thing I wanted to touch on is that this is straight from my notes from the day. The mother had been taken away from the scene by the police, had been taken into the house. And we were quite clear that we wanted her involved in resuscitation. I know that Georgina mentioned that, mentioned the parental involvement in the resuscitation in her talk. But this is something that over the years, and certainly since I've become a parent, this is something that I think is critically important and we must do better at and we must think about. Because I still remember the time that any resuscitation, you got the family out of the way, you put them in the relatives' room and you carried on with your resuscitation, and then you went and told them what was going on. And I remember taking parents out of the resuscitation room and away from scenes, putting them somewhere else. And I have to say that to me now as a parent, there's no way that I'd be moved from where my child is being resuscitated if that was the case. So why is it that that culture has crept in, or maybe a historical culture now? There's some work out there, some qualitative research out there about not only staff views on parental presence during resuscitation, but also providers and healthcare practitioners' views about parental presence or family presence during resuscitation. And these will all be available for you to have a look at on the Facebook streaming. But the bottom line is a couple of these studies. The top one there is a survey of 400 parents. When you actually ask them, do they want to be there? A lot of them actually do. But funnily enough, the desire to be present seems to decrease with invasiveness. So they want to be there for the invasive procedures. They want to be there for the procedures that maybe the child needs even more support and wants that parental presence. But they're not that worried about being there for simple things like perhaps a cannulation, although I know that that can sometimes be perceived as being invasive and difficult for the child. But that's almost the opposite of what we as providers might be tempted to think. We might be tempted to think, oh no, we're about to do a thoracotomy. They absolutely wouldn't want to be there for that. If you ask the parents themselves, that's the exact type of procedure they want to be there for, with the invasiveness going up. When you look at questions around resuscitation specifically, every single parent wants to be involved in the decision-making around resuscitation. And we all know that that decision-making is so fluid and fast-moving and responsive to new information coming in, that the only way we can really get them involved in that resuscitation decision is to have them there in real time with us, stood next to the team leader, understanding the decisions that are being made. Particularly, again, this is maybe converse to what we might think, particularly if the child is likely to die. They definitely want to be there. Something about having closure, something about wanting to be there at the end and seeing that everything has been done and being there to provide support, which again, perhaps is the opposite of what we might be tempted to think as healthcare practitioners. And as I say, it's probably something around the processing of the tragedy afterwards, something about being able to access that support and that emotional side of things. What was also quite interesting, this was a study that looked at parents who had been present at end-of-life events in their children. And again, something that maybe takes away the worry for us about the parents having this sort of post-traumatic stress type response to the resuscitation itself or the procedure itself. Most of the parents who are asked actually don't remember the specifics of it. They remember that there were a lot of people trying to help their child. There was, control, there was calm, there was leadership. They don't really remember the specifics of this scalpel incision was made, this intubation was done, this suction carried out, there was lots of blood. They remember the professionalism and the kindness of the teams that were trying to help their child. So why is it that still, I think, perhaps our instinct, particularly more junior or less experienced people, is to move the parents away? It's probably more to do with us than it is to them. It's probably because we find it emotionally difficult. We find it added pressure to have the parents there. But I think that that's probably something that's changing, and I hope it changes, and I hope that everyone sitting in this room and watching online will be thinking, there's no question I'd have the parents there. I think that's something that we're moving towards. And in fact, if you survey staff, 70%, 75% of nurses do believe that it's important for parents to be there. Interestingly, 60% of nurses asked in that particular study felt that it was the doctors that didn't want the parents present. So for those doctors out there, I challenge you to think about that decision. If you're going to make that decision, if you think that that's the right thing to do, just stop and think again and challenge why it may not be the right thing to do for the family and for your nursing staff and your team. Okay, so moving on from that, let's get into some specifics of paediatric trauma. So maybe something that you can take out onto the road or into the emergency department for the next major trauma patient. The approach to paediatric trauma, it's a rare event. So most land crew, paramedics, ambulances will see 1 or 2 major trauma patients a year perhaps. That's all comers. When you look at paediatric major trauma, so injury severity score greater than 15, so critically injured children, it's probably even less than that. It's maybe 1 every couple of years. Some people have worse luck, but typically if you look at averages, it's not that many. So it's a rare event, which is why it's maybe a bit more stressful. But the approach is actually the same as for adults. It's an ABC approach. It's a systematic approach to using the trauma triage tool, which we'll talk about. So it is the same, but there are very specific considerations around some of the ways in which the injuries occur and some of the consequences and sequelae of those injuries. So first and foremost, it's a different mechanism of injury. So because of the relative size of the head compared to the body in children, and because of the things that children do, like climbing on things, like falling down stairs, like falling out of trees, it's mostly head injuries, 85% head injuries, and it's mostly related to falls, sporting accidents, and then there's this sort of tranche of drownings and burns that we get. Far fewer RTCs, road traffic collisions, and assaults, which is what we tend to see, certainly in this region and in London, in the adult population. We're seeing assaults, we're seeing stabbings, we're seeing road traffic collisions on our big networks of roads. So this is important, not because you need to know the epidemiology of this trauma, but when you're preparing yourself for what this patient is going to look like when you go to them, you need to be thinking, this is going to be a patient with a head injury, so I need to start thinking about my head injury, my neuroprotection, dealing with children with head injuries. So it's just important knowing that epidemiology in terms of your own preparation for what you're about to see. And there are certainly different patterns of injury and different sequelae. So if you look at the airway, and we talked a little bit about this in the first talk, the airways are already small and narrow. So anybody who's done laryngoscopy on a child and looked down the hole that you're supposed to put the tube down, it's a tiny hole. It's 1 centimetre, 2 centimetres maybe, much, much smaller. Everything's smaller, except the tongue and the epiglottis, which the tongue fills the whole mouth and the epiglottis is big and floppy and baggy, goes over the top of the laryngeal inlet, and you can't really see where you're supposed to go. And not only that, the mouth cavity, when you are trying to manage the airway, is relatively small. So it means that it's difficult to get your laryngoscope in. It's difficult because of the positioning of the tongue and the size of the epiglottis and the relative size of the soft tissues compared to the mouth cavity to get that patient in the perfect position to move their tongue and their soft tissues away from occluding the airway. And you can see on this picture here, the top picture is a child just lying flat, and we know that the big occiput pushes the neck into flexion, but look what it's done to the tongue. The tongue is sitting back, the high anterior larynx is flexed slightly and almost occluding where the base of the tongue is sitting and the soft tissues around the pharynx. Just by putting them into that neutral position with a blanket underneath the shoulders, getting them into a nice neutral alignment, which by the way is also keeping the cervical spine in a straight line. The top picture there, just a child lying flat, has got the cervical spine flexed. So something underneath the shoulders not only manages the cervical spine alignment, but it also lifts those soft tissues, prevents the flexion and the kinking of the high anterior larynx, and lifts the soft tissues away from occluding the airway. So that's something worth knowing, I think. That point there about the high anterior larynx doesn't only hold true for what we've just talked about in terms of the flexion and extension, but it also is quite important when you come to intubate the patient and you're expecting to see, instead of a laryngeal inlet that's at about C6, C7, it's much higher and more anterior. So getting your angle right to intubate them is much more critical. So we're talking a little bit still about airway stuff, but this sort of holds true for all of your equipment and techniques and trainings. Familiarity is key. And I'm going to go slightly off-piste here, and I'm aware that I'm probably about to say something that a consultant paediatric anaesthetist probably wouldn't support. But my view, having done this for quite a while now, is it's better to use a technique that you're familiar with rather than to try and adapt a technique that's specifically designed for a child. And we'll come on to that in a second. I want to remind you in a couple of slides' time about dead space and ventilator capability, and you should know your own ventilator capability. And just a point to think about, that muscle memory, this is the ability to do things repetitively and in a slick way, is about how things feel, not just the actual movements of your hand. So it's how things feel in your hand. So this is what I mean about familiarity and maybe adapting a technique that you're used to using if you're primarily an adult practitioner, rather than changing a technique for this rare event. So many of you will be aware that there are two types of laryngoscope blade out there and available. There's these straight blades and there's the curved blades. And the Miller blades are the straight blades and the Macintosh blades are the curved blades. The idea of the Macintosh blade, that's that curved blade that you intubate adults with. The idea is that you put it in, it curves around the tongue, sits at the base of the tongue in the vallecula, and as you lift it forward, you lift the epiglottis up. And people who intubate patients will recognize that feeling of getting into the vallecula, seeing the epiglottis, lifting forward, and seeing the epiglottis open up like a trapdoor. Now remember that we said that paediatric airways have big floppy epiglottis, a big floppy epiglottis sitting there blocking that trapdoor. The idea of the Miller blade is that you put the straight blade, it's not curved, so it doesn't curve around the tongue, you put the straight blade beyond the epiglottis and you lift the whole lot forward with the epiglottis as well. And the idea then is that you can visualize that high anterior larynx a bit better. And you can see that in the pictures at the bottom. So the left-hand side, picture A, is the tip of the Macintosh curved blade in the vallecula, and you can see that the epiglottis is sitting behind it, that triangular shape behind it. It's about to be lifted forward as you pull anteriorly. The tip of the Miller blade in figure B there is squishing the epiglottis and the other soft tissues anteriorly, so you can directly visualize that view. Now, what I'll say about familiarity is, for me, the feeling of a curved blade going into the mouth, sliding along the tongue, sitting in the vallecula and lifting forward is as much a muscle memory as the actual movement of putting it in itself, that feeling of it going in. So feeling a Miller blade going in and having to remember to put it in a little bit further and maybe not quite tilt it or lift it in the same way as I would a Mac blade actually makes it much more difficult for me. Even though I know theoretically the Miller blade is the pediatric blade, I'm much more comfortable using a small Macintosh blade. So I think the familiarity offsets the potential advantage of doing it a different way. So if you're using your Mac blade every single day, or if you're using your Mac blade for your 20 intubations or 30 intubations a year that you might end up doing, stick with the Mac blade, go with a smaller Mac blade, use that same muscle memory to intubate the child. Give it a go. If you're struggling with the Miller blade, if you're struggling on a mannequin, if you're struggling in real life, give it a go reverting to the smaller curved blade, use that same muscle memory and just see if that gets you out of jail a bit. Similarly, the difference between a very thin laryngoscope handle and a normal size laryngoscope handle just throws you off with that feeling of the muscle memory going in. So keep everything as close to possible as to the things that you are used to and are comfortable with and are trained on. And not only that, make sure that your approach is the same too. So this is this is a much younger version of me 10 or 15 years ago now, doing an RSI on an adult on the roadside. And I can tell you that almost every other RSI I've done on the roadside has looked like this. People around the patient with very specific roles, a kit dump to my right-hand side, a paramedic to my right-hand side, a checklist. You can see the checklist on the floor there that we've just gone through. All of our equipment checked, all of our equipment primed, everybody briefed with a very specific job. That familiarity of us all clicking in, forming that flash team, that ad hoc team, and bringing some sort of order to the chaos and the difficult, emotionally difficult case that we're about to deal with. So regardless of how blue and awful and scary that child looked coming out from under the car, I need to convert that scariness and that emotion into this picture in my head. This is where my mental model is of doing an RSI. This is what it should look like. So the familiarity is the key there. So default to your level of training, have the same system every time, have the same process every time, and adapt the patient to that process and not the other way around. And that's equally true for patients who get intubated in resus or in an anaesthetic room. I think you can have basically the same recipe for every single patient who you intubate. So take the time to go through a checklist, take the time to brief the nurse, take the time to have the assistant properly positioned with the equipment in front of you and not behind you. Make it the same every time and make it easier just to slot into that process when the emotional pressure is on. Okay, moving on to ventilators. So this is the good old Parapax. This is on most ambulances in the east of England. Some of the helicopters carry them. The point here is about knowing what your minimum tidal volume is. So children, it's the same tidal volume. It's 5 to 7 mils per kilogram. So if you have say a 10 kilogram 1-year-old, 100 mils, which is the lower end of the normal range of the Parapax ventilator, is actually over-ventilating that child. So even if you intubate this 1-year-old and you want to ventilate them post-cardiac arrest or in the context of a pre-hospital anaesthetic, and you dial your Parapax right down to the minimum that it will possibly go to, that's still going to over-ventilate your child. So the take-home message here is know what the lower limit of your ventilator tidal volume is, and do the calculation for what you think the tidal volume should be every time in a child, because it will quite often be lower or very tight to the lower end of the abilities of your basically adult ventilator. And whilst we're on that, this gets us every time. So this is the concept of dead space and tidal volume for children. So when we do that RSI, the pre-hospital RSI, or even indeed a hospital RSI in the emergency department, we'll hook the patient up to our ventilator, but we'll hook them up through a whole series of tubes and pieces of equipment. And each one of these takes a bit of dead space. And dead space is basically air or gas that's being moved through these pieces of equipment, but are going nowhere near the child. So if you have a look at the HME filter on the left, that's 35 mils. The inline end tidal CO2 at the bottom left, that's 10 mils. The catheter mount, which is 40 mils, some of them Constantina down to about 20 mils. You've got the ventilator circuit, the hose itself, which is 30 mils or so. And then you've got the bit of the tube that isn't all the way down. So remember the calculation for the length of tube. So in an adult, it might be into 22 centimetres at the lips. In a child, it might be 12 centimetres. So if you've got a 28 centimetre tube, you've potentially got 15 centimetres or so of dead space that air's just moving up and down through. So if you add all of that up, which is just standard to put onto a ventilated patient, you've got a total circuit dead space of over 130 mils. Now, if you come back to our patient who's been dragged out from underneath the car, who's 18 months, if you work out their tidal volume, 5 to 7 mils per kilo, you're looking at 60 to 80 mils. So in fact, if you're ventilating a child who needs a tidal volume of 80 mils with a circuit dead space of 130 mils, you're basically not ventilating that child. You're just moving the air through and backwards through that dead space. And soon the end tidal CO2 begins to rise and rise and rise. And you think there's a problem with the patient, whereas actually it's your dead space. So one of the take-homes from this is, although I've just said to you, make sure you keep your systems the same, there are parts of the system that you have to actively think about changing. Actively think about having the correct size HME filter or getting rid of it. Actively think about cutting the tube when you're happy that it's in at the right place, cutting out that dead space. Think about maybe using a side stream end-tidal CO2 monitor instead of the inline end-tidal CO2 monitor. Think about using the specific paediatric ventilator tubing, all to reduce that dead space down. You don't need the catheter mount, that's just a convenience thing to stop the kinking. Use something else. So unless you think about that, you're going to have an issue with your end-tidal CO2, and I'll show you the OBS trace, which shows you that I didn't think about it quickly enough in this case. So whilst we're still on B, I think everybody probably who has been involved in anaesthetising children or in sick children knows the horrible noise of the pulse oximeter beeping slower and slower and slower in about 5 seconds after you've put the anaesthetic in, as the saturations tumble and tumble and tumble and tumble, and they just drop like a stone. And that's very different to the concept of the 3 minutes of pre-oxygenation in a normal adult that will give you maybe a couple of minutes, maybe 3 minutes of good high oxygen saturations whilst you're trying to get a view with the laryngoscope. Children desaturate quickly. They've got a high base metabolic rate. They've got relatively low physiological reserves. And not only that, in traumatic injuries like this one, they're particularly prone to actually mechanical pulmonary injuries, so injury of the lungs themselves, because the rib cage is soft and doesn't protect them as much as the rib cage potentially does in adults. So it's not uncommon to have a child who has no rib fractures at all but has multiple bilateral pulmonary contusions. So a normal child on a good day will desaturate super fast. If they've got a sniff of a pulmonary injury, they'll desaturate like a stone. And particularly in this case, with the weight of the car on top of the chest, that was the case here. So we were expecting that desaturation drama. So what you can see here is the OBS trace from this child. So we pulled them out from the car and we'd started to, wasn't really breathing very well, still looked purple, clearly had an element of traumatic asphyxia. So the pressure of the car pushing against the flower bed and being face down with the face occluded had given an element of traumatic asphyxia. Mechanically couldn't get air in and out of the lungs for a few minutes. So not really a chest injury per se, no rib fractures, hadn't been run over by the car. This was more of a asphyxia injury than it was a traumatic injury. So just by managing the airway, by ventilating, hand ventilating with a BVM, we were able to, as you can see from the left-hand side of the observation chart, we were able to get the saturations up to 100%, and we put some end-tidal CO2 in the circuit, and the end-tidal CO2 was fine, because we hadn't put all of that extra dead space in. So we were hand ventilating, but with a big swollen face, engorged face, SVC territory obstruction, lots of capillary leakage, swollen lips, swollen tongue, and when the child had been spontaneously breathing, seesaw breathing, so a partially obstructed airway, which is much more visible in children, again, because of that soft chest wall being pulled in. So there's a real temptation, actually, when we're managing the airway, and as they said in the neonatal life support, you can go into hospital with a Goodell airway and just hand ventilating. We had SATs of 100%. So there's a real temptation, given the relative proximity of Luton Hospital, to just take this child in on a BVM with saturations of 100%. However, children's airways are small to start off with, and this was a small, swollen airway that was only going to get worse. So my feeling was at the time that, like a burn, you have to secure the airway there and then, otherwise it may occlude to the extent that you won't be able to secure the airway in 10 minutes or 20 minutes or an hour, however long it takes you to get to the hospital. So I felt that the critical intervention here was to get a tube in, secure the airway, and take the patient to hospital at that stage. So we formed that flash team, and you can see that there's a sort of period here that we're forming a team, sort of 10 minutes or so, getting the patients into the right position, briefing people, going through our checklists. And you can see the first dip at the top up there was the first look with the laryngoscope, which didn't last very long because the SAT started falling straight away, and we thought it was best to come out and sort of think again and reventilate, because we put the laryngoscope in, or I put the laryngoscope in, and I could literally see nothing recognisable. It was just all tongue, it was all secretions, it was swollen, it was distorted, and I couldn't see anything. I couldn't see anything that even looked like an epiglottis or a hole to put the tube through. So I probably muttered something under my breath that only the paramedic next to me could hear, probably not for live streaming, and we came out fairly quickly and rebagged up to 100%. Now in a situation that we've got a really potentially difficult intubation in front of us, and we've got a child who we've committed to anaesthetising. But we're still able to ventilate to 100%, so again, the thought process and the conversation we were having was, do we just move at this point? Do we just get to hospital? Do we just try and get somewhere that there's maybe a paediatric anaesthetist or maybe a wider team available to assist us? And again, our feeling was that we wouldn't make it that far with the state that the airway was in at the moment, and the fact that we just looked at it and it was all swollen and unrecognisable pushed us even further down the route of trying to get this tube in. Although I have to admit that the thought of doing a surgical airway in this child with a swollen neck at the age of 18 months didn't thrill me, for sure. So we had a second look, and you can see here that this is an observation chart that you wouldn't be terribly happy with if you're an anaesthetist in theatre. You can see that the saturations go from 100% to 59% fairly quickly. And it felt like it just went like that. But by moving the front of the larynx around, moving the front of the neck around, doing some external laryngeal manipulation, I'd spotted a little bubble that had been dislodged, and an air bubble suggests an airway. So the SATs are now 80%, and the paramedic's saying SATs are 80%, SATs are 70%, SATs are 60%, SATs are lower, SATs are not recording, patient's blue. But there's this bubble, and it was a case of just accepting that this is the best view you're going to get, the saturations are going down, and you now need to get the tube in. So following the bubble, looking at where the bubble's coming from, pressing on the chest, moving the neck around, and seeing if there's a bubble can sometimes get you out of jail in these swollen, difficult airways. So we managed to get a fairly small tube for the size of the patient, a size 3.5 tube, I think, through where the bubble had come from. Fortunately, it passed through, and we were able to ventilate fairly quickly back up to saturations of 100%. So high fives all round, and connect all of that clockwork that we've just shown on the previous slide. And sure enough, true to form, like every single time, the end-tidal CO2 goes up from a nice 3.8, 3.7, 3.4, up to 5.8, up to 7, up to, again, 7, 7.8, 8.2. And that's the point at which you have to remember to strip down the circuit, and you have to remember that the ventilator you're using doesn't go down that low. So this is why the pink line here is the respiratory rate. This is where we switched to handbagging the patient to try and get rid of all of the ventilator circuit, to try and get rid of all of the dead space, and just handbag them to hospital in the back of the helicopter, keeping hold of the tube, making sure that we're ventilating and trying to get the CO2 down, although not really succeeding. And some of this was around the crush injury and the metabolic offload that the child had as well, with a high lactate and generating the CO2 from it. But stripping down that dead space, particularly in a patient who you think has got a hypoxic brain injury, actually becomes really quite important. Okay, so we're not going to look at that OBS chart for too long because I don't like that big dip, but hopefully I've explained it. Let's move on to a sort of C thing. So this is just a very quick reminder that children don't have that much blood. So in general, adults have got about 5 litres of blood kicking around. So you lose about 2.5 litres. That's your, what we used to call grade 4 shock. That's your half of your blood circulating volume. That's tachycardic, hypotensive, shocked patient, pale, sweaty, in resus in front of you. 2.5 litres is actually quite a lot. If you imagine emptying out 2.5 bags of normal saline onto the floor, that's actually quite a lot of blood. If you look at a 1-year-old at 70 mils per kilo, which is your typical blood volume for a child, that 1-year-old has got about 700 mils. So to put it into context, losing about 50% of your circulating blood volume if you're a 1-year-old is the equivalent of losing a can of Coke. So if you go to one of these patients and you see a small pool of blood next to a 1-year-old that's about the size of a can of Coke, that's half of their circulating volume. So it's worth just conceptualizing that, thinking about how shocked that child must be. And of course, because it's a child, it compensates. So they'll probably not be hypotensive, but they will be tachycardic. They have a fixed stroke volume, so they compensate by generating a tachycardia. So a child who's got half a can of Coke, 3/4 of a can of Coke of blood loss on the floor in front of you, who's really tachycardic, actually is as sick as that sweaty, pale, 2.5 litres of blood loss adult that you might have in your head as the concept of a shocked adult. So think about circulating volume. And again, it's probably not a bad thing, not a bad habit to get into, that you go to a 3-year-old who's 15 kilos, just do the quick calculation in your mind, or have a look at a crib sheet that hopefully you'll have all printed out by now. Just think, okay, well, what's that circulating volume? Okay, well, we've got a femoral shaft fracture, so that's probably 50 mils or 100 mils, and that's X amount percentage of their circulating volume. And it really focuses the mind into thinking about how compensated this patient is and how sick they actually are, even if they don't look it. And children look quite well until they don't. Okay, so let's get back to our patient who we've now got a tube in. We've stripped down the dead space. We're hand ventilating. We've now got this decision to make. And this is where I think the paramedics out there who have perhaps gone to this case as a paramedic technician or a road crew response without HEMS backup, without a level 3 team available to manage the airway, perhaps go a different route to the route that we took. But the big decision here was, do we go to a hospital, a paediatric major trauma centre, so with a paediatric intensive care unit, or do we go to the nearest acute hospital? And you saw on the picture earlier on that the nearest acute hospital was Luton. That was about 10 or 15 minutes by road. There was that sort of bumpy farm road bit, but it was 10 or 15 minutes by road, so not very far away at all, actually. Adam Brooks, 60 minutes by road, maybe a little longer at that time of day, but 20 minutes by air. And clearly, now that we've got the patient intubated, we've got saturations that look okay, we've got a secure airway, we can take the decision to bypass that nearest acute hospital, fly the patient, use the helicopter transport platform to get to the hospital fairly quickly. But even if we couldn't fly, I'd have still put the patient in the back of the ambulance and driven that 60, 65 minutes to Adam Brooks, because I'd taken care of the immediate needs. So when you're making your triage decisions, there's obviously the triage tool, which we'll look at in a minute, but I think you should also be asking yourself these questions here. So what does the child in front of me actually need? So before we put a tube in, what they actually need is to be intubated. So they need to go somewhere where somebody can intubate them. And if you're a paramedic crew who can't do that without drugs in this case, you can't deliver anaesthetic drugs to this child, you have to go to the hospital that will be able to deliver that intervention for you and get there as quickly as possible to the nearest hospital that you can go to. So that's probably a decision to go to the nearest acute hospital, which is Luton in this case, to have that intervention delivered for you. We were able to deliver it on scene, so we took away that decision making. If you don't think that the child needs something now, do they need something in an hour's time? So that's typically an immediate operation. So to go to theatre to have a splenectomy or damage control resuscitation or a thoracotomy or something. And that's where it gets a bit tricky with that sort of 45, 60-minute window that the triage tool talks about, because that's why that's in there. So can you get to the major trauma centre to deliver that intervention that the child needs within an hour? And then what's the child need, and do they need it in 4 hours or 24 hours, which can work in two ways. In my mind, it works as get them to the right place that they'll be able to get that care in 4 hours, because we know that the trauma network might not necessarily be able to transfer the child from hospital A to hospital B within that 4 hour period. By the time they've come into hospital A, been resuscitated, gone through the CT scanner, a communication has taken place between the network coordination service, hospital A, hospital B. We've got an ambulance to come and take the patient. We've got the transfer team out to take the patient to bring them to Adam Brooks or a major trauma centre. We know that that's probably pushing on 4 hours. So if the child needs something within 4 hours, my temptation is always to take them to the place primarily that can deliver that intervention. And if you're a road crew, remember in this region that the network coordination service consultant can support you in bypassing local hospitals for a child who maybe doesn't have any immediate needs, but does have needs at a major trauma centre, maybe in the 3 or 4 hour mark, and we can support you on the end of the phone to make that decision. So just to remind you around the trauma triage tool, this is fairly standard across the country. The wording's slightly different, some of the criteria is slightly different, but in the east of England, the question you ask is, can the major trauma centre be reached within 45 minutes? If yes, can airway, breathing and bleeding be controlled? And I would argue that in this case, airway could not be controlled in that 45-minute journey. So for this case, if you're following the trauma triage tool, you divert to the nearest trauma centre, the nearest trauma unit, or the nearest acute hospital. And I think we've talked about ambulance versus HEMS here. Okay, so that gives you a snapshot of this case and some of the considerations, some of the wider considerations around paediatric trauma. I just wanted to finish up touching on looking after yourself and looking after your team, because I think this is actually really quite important. And I think that most of us who respond, go out there, deal with emergencies in the emergency department, most of us will worry about or think about or take with us the paediatric cases. They're the ones that are the most emotionally challenging, I think, because you've got the child plus you've got the parents, and they're certainly the ones that I carry with me when I think about cases that I've been to. So I think it's important to have your team, and it's important that you are genuinely a team. I'm going to show you a video. It's important that you're genuinely a team, and it's important that you look after each other and you know your teammates. So I just want you to watch this, which I think captures that team dynamic between a doctor, me as it happens, and a paramedic, and how we can work together to both deliver good patient care but also to look after each other. When we take patient's breathing and deliver an anaesthetic at the roadside, we have to put a tube down into the lungs to take over their breathing, and sometimes it can be challenging to put that tube in the right place. It's something that we practice over and over again. Literally every day we'll practice it or think about it. We can do some very complex jobs, Gemma and I, and because we've worked together, we're often on the same page, and we can do quite a lot of things even without talking to each other, just that sort of non-verbal communication.
Yeah, you can sometimes look at each other and you can just see that they're not happy about something, so it might then be that you need to say to them, what's going on, what are you worried about?
I think a really good example is going quiet, isn't it? We know that if Gemma goes quiet, I know that there's something not quite right, that maybe there's something with the patient that I've missed, or there's something with her that I've missed, or we need to have a bit of a chat about something. Because little things like that can actually make the difference between the outcomes for our patients. So I think the point of this is knowing your team not only enables you to work effectively together, but it enables you to recognise when something isn't quite right the following day or the following week or even the following months and years after one of these difficult cases. And if you know your team and you're close enough to them to recognise that they're not quite right or there's something about them that isn't right, I'd encourage you to ask them, to talk to them, to challenge them on it and be empathetic and supportive towards them. There's nothing, I don't think, like forging a bond through a shared difficult experience. And quite often people at home don't quite understand what you've been through, and it's the people who are there with you that do. So talking to those people becomes really important. And I think that point's highlighted in the latest guidelines for mass casualty events from NHS England. I think probably many of you have heard of TRIM services. So if I say, if someone's had a difficult job, quite often the reflex is, give them a TRIM referral or generate a TRIM referral for them. But in the NHS England guidance, TRIM referral is actually quite a long way down the algorithm of what you should be doing. Right up at the top here is peer support. So that initial support of having a cup of coffee, having a cup of tea after the event, going for a beer afterwards, making sure someone's okay with a text message later on that day or the next morning. That's actually the initial support that a lot of people want, but don't necessarily know that they want. So I'd encourage you to think about that. If you know that your teammates and your friends have gone to difficult jobs, have been at difficult jobs, have been in difficult situations, it's the right thing to do to start that process of just asking if they're okay. And the good news is, of course, that these things do sometimes have a happy ending, and we've talked quite a lot about non-happy endings, but this is the child a year later who came back to visit us, doing really well, lots of smiles, perfectly normal child, normal development, and genuinely I think a life saved by the entire process from the 999 call taker all the way through to the paediatric intensive care unit, the paediatric rehab ward, and the specialist rehab teams that got involved later on. So these things do sometimes have good endings, and I think that they have good endings when you've thought about some of the things that we've talked about tonight in advance, and the first time you're dealing with it isn't when you've got a patient in front of you, because you've already prepared yourself for it. So just to reiterate those take-home messages then, don't do calculations, burn your whiteboards, use a card or an app. You can get apps on your mobile phone. If you're in the back of an ambulance or in a helicopter, you can just get the app to calculate it for you. Keep the parents involved and next to you as a team leader or as the doctor on scene. I'll have the parents standing literally on my right shoulder, and I'll be talking to them and telling them what's going on. And I think it's worth remembering that your system and your standard operating procedures, your usual day-to-day processes, if you stick to them, they'll probably save your patient's life, because we all sync to our level of training and we all fall back on our system and our competence and our confidence zone when the chips are down and when we've got a really emotionally challenging case. Children are certainly challenging. There are bits of their airway management, their breathing management, their circulation management that are challenging, and you have to learn new muscle memory, which is as much about feeling that small cannula or the different size of laryngoscope, the different weight of laryngoscope, the different width of intubating bougie. It's as much about that as it is about the actual muscle skill itself. Children do desaturate fast. You'll all see children desaturating fast when they're sick. Sometimes, however, you do just have to accept that and make a conscious decision that you're going to deal with it, but you need to do something else first. So you accept that the SATs are going down and you crack on and you make sure you get the SATs up as quickly as you can. Because children are quite resilient when it comes to periods of hypoxia, and certainly a 30-second period of hypoxia that you rapidly correct. It's actually more important to deliver that intervention despite the saturations dropping like a stone. Dead space will get you every time. It gets me every time. I lecture on it, I talk about it. It gets me every single time until I remind myself to remember it. So try. Swollen airways will get worse. This is burns, this is traumatic asphyxia, much, much worse. They will completely occlude, and they were only tiny to start off with. So you have to be super aware of that in terms of your decision making as to when to secure the airway, your anticipated clinical course. And I think that this is probably becoming more and more important to me personally, but also I think we're as an NHS family we're aware of this. Know your team, know the people you work with. Definitely celebrate your wins together. have the photographs taken, meet the family, read those thank you letters that get sent in, and enjoy that, celebrate it together because they are genuine lives saved, but also support each other when it doesn't go so well. And even in the cases that do go well, they can have taken an emotional toll on you. So support each other, support your friends, offer that peer support, make the cup of tea, send the text message. And that's it. Thank you very much. Does anybody have any questions?
Yes. In regards to what you say about using the cards, I know with a lot of paediatrics, they try to refer to the child's weight more than they do their actual age. And I did say on your cards of like the average weight of the child, but obviously you can get young kids who weigh as much as an adult, you can get other kids who weigh as much as a baby.
Yeah.
And it's just how you say don't do the calculations, burn the whiteboards, but then how much should you, like when you don't know, pay attention to the weight more than you should just maybe have an average card and just stick with that?
Yeah, I think that's a really good point. So I think we put the age at the top of these cards because that's really the terms in which we get given jobs, don't we? Or we get given a pre-alert. Your at-mist is the age. You get given a job, you know, you're going to a 5-year-old who's fallen off a trampoline. So it's probably more convention. We could just as easily have the weight up at the top there. So we say this is the 14 kilo card, this is the 16 kilo card, this is the 20 kilo card. And a lot of parents will know the exact weight of their child. So if I went to a 3-year-old who the calculation says, as it happens here, that it's 14 kilos, and mum says, oh, actually it was 20 kilos last time I went to the health visitor, I would just flick to my, whatever the age is, my 5-year-old card that has 20 kilos on it, and I'd go off that weight as well. But remember that it's not necessarily about the weights for equipment, it's weights for drug doses. The length of the trachea and the size of the lungs might be the same regardless. So you do have to, this is a starting point, so you do have to think about it as well. But what I would say is if you stick to the pre-calculated cards, you're probably going to be in a safe zone, but you have to be wary that you might need to go up or you might need to go down, particularly with drug dosages. Okay, I think we've got a stream question.
Thank you. We've got a question from the live stream. In keeping with fireworks night coming up, is there any top tips around management of burns in paediatrics?
Yeah, so I think burns, the top tip around burns, if I had to say one thing in terms of the sort of public message out there, it's to not overdo the cooling. So you only need to cool the bit that's been burned. So if they've burnt their hand, you don't need to throw them in the shower, in the cold shower, and cool their whole body, because their body surface area is such that they will lose heat very, very quickly. And I think almost every home-cooled child who I've been to as a HEMS call or as an ambulance service call has been sitting there shivering, full of shower or been put in a cold bath. So only cool the burned area, so the area of the burn, and only cool it for a maximum of maybe 15 to 20 minutes, because after that no further cooling is necessarily required. And that works similarly for the ambulance service for those cooling gel things, the burn gel dressings or the burn shield dressings. They're designed to acutely cool the burn. They should be covered to prevent evaporative loss. So patients who come in with those very nice smelling actually things all over them with no covering are often also hypothermic as well. So if you are going to use those burn gel dressings, either take them off at the 20-minute mark or cover them with a simple sort of ambulance service dressing to stop that evaporative heat loss. That was a left field question.
Could you just talk a little bit about pain management in paediatrics, if possible? Because I don't have that much experience of pain management in paediatrics. When I sort of ask my more experienced colleagues, it's not really that much there.
Yeah, so the question is just around a general approach to paediatric pain management. So most parents will tell you Calpol and Nurofen, which is absolutely what I would start with. So most children who I see in A&E who have pain will either get ibuprofen or Calpol. I'm a fan of intranasal, either fentanyl or diamorphine in the emergency department and in the advanced pre-hospital care setting, so I'll go for that. Usually as a bridge to getting a cannula in. So I'll often give some nasal diamorphine or some fentanyl to calm the child down enough to get a cannula in, and then I'll just default to my intravenous morphine boluses, age-related and weight-related boluses. So not a dissimilar approach to adult pain management, but thinking just a little bit more about some of those reassurances with the parents being there, being able to get the cannula in. But the gold standard is intravenous analgesia. And I'm a huge fan of ketamine for particularly unpleasant procedures, such as reducing fractures. So I'll give them a good slug of ketamine to do that. Any other questions? Anything else in the stream?
There's just one more on the stream about dead space in paediatrics, but I think it's probably more an in-hospital, so just give your comment, but about Mapleson systems or T-pieces, but I think that's more in-hospital, not available to pre-hospital setting.
Yeah, so this is just around those, the circuits that you'll often see anaesthetists use, either with a Mapleson C or with a T-piece. My feeling about that is if you know how to use them and if you're practiced in using them, if you use them every day in your practice, that's good. Not dissimilarly to what I said about the Miller blades. Don't go to one of them just because you think that's what you should use in a child. Stick with the BVM. There are theoretical physiological advantages in terms of adding PEEP into the system, about keeping the lungs inflated, about improving your oxygenation, which is critically important in children, as we said. But those advantages are probably outweighed in inexpert hands. So people who aren't doing this regularly just reach for the BVM and use that muscle memory and that familiarity with the BVM.
I've actually got two more, if everyone's okay with that. The next one is...
to go home.
We'll keep it quick. Given children's fixed stroke volume and their delay for developing hypertension in hemorrhagic shock, would the thresholds be different in transfusing blood products to adults? And if so, what would the differences be?
It's a really good question. So I think the threshold probably does change. So we talked about what the child who is shocked with hemorrhagic shock or hypovolemic shock looks like compared to the equivalent adult who's lost an equivalent volume. So I think don't be tricked by a child who's looking fairly fit and healthy in front of you, but is just a bit tachycardic. If you think they've lost volume and you think they're compensating, it's certainly not a bad thing to give a volume challenge, be that with blood or with a bolus of fluid, to see what the physiological response is, because they will often, as I've said, have lost more than they perhaps appear to when you're not used to looking at sick children who are hypovolemic.
The final one is what differences are there with between adults and paediatrics for spinal immobilisation, and what's the current guidance?
So I take a pragmatic approach. So the first thing to say is spinal cord injury in children is incredibly rare. It's less than 2% of major trauma patients. I take a pragmatic approach. If you've got a squirming child who won't stay still, forcing them down, taping them, trying to put a collar on is going to be counterproductive. So I just get them to be in a position that they're comfortable with. I try and use the parents. A ventilated child, I'll probably just use rolled up blankets or head blocks just to keep the head nice and straight. And remember that in the smaller children, the flexed position because of the big occiput is actually flexing the cervical spine as well. So you might want to put something just underneath the shoulders to keep the cervical spine in a nice straight line. I wouldn't necessarily put a collar on. Good. Okay. So take home messages are there, and we'll say goodnight and see you next month, hopefully. Thank you very much. Just in terms of the attendance and feedback, that's the tiny URL for your feedback. If you can fill out the feedback form, there's a link at the end to download a certificate from for CPD. And the next form is on the 21st of November.